Hello, everyone. Thank you for joining for the ISHLT webinar. The topic for today will be the multidisciplinary approach for diagnosis of antibody-mediated rejection, AMR, in lung transplant recipients. I am Adriana Zeevi, one of your moderators, and I have the honor to co-moderate with Dr. Ramzi Hashem and a panel of excellent expertise that will discuss and illustrate through a case the complexity of lung AMR. In the next slide, we summarize what will hope to be the learning objectives for this presentation. First of all, to enhance the awareness of antibody-mediated rejection as a cause of active lung allograft dysfunction. To understand the nuances of donor-specific antibody and of the percent of donor-derived cell-free DNA testing and how we can implement in our diagnosis. And then recognize pathology findings commonly seen in AMR and emerging surrogate markers. Dr. Hashem will be illustrating a case, and as we finish, we will have time for discussion. Please enter your questions in the chat. Thank you very much. Ramzi, please take it over.
Thank you, Adriana, and thank you for organizing this webinar and getting us all together to present this case and the information that goes along with it. I think it'll be an exciting webinar for sure. And thank you to the audience for being here. This is a real case that happened at our center. The patient is a 33-year-old man who had cystic fibrosis and had a bilateral lung transplant in February of 2025. His induction immunosuppression was basiliximab, and he was treated with tacrolimus, mycophenolate, and prednisone for his maintenance immunosuppression. He had serial surveillance bronchoscopies and had no episodes of acute cellular rejection on those surveillance bronchoscopies. He did have recurrent positive cultures from bronchoscopy specimens for Pseudomonas aeruginosa. And those positive cultures were treated intermittently with a combination of systemic and or inhaled antibiotics. The patient was seen in early September of 2025 for a routine clinic visit. He was doing well. He had no respiratory symptoms. His pulmonary function tests are shown on the right of the slide. And his FEV1 was 2.67 liters, or 83% predicted. And that was at his post-transplant baseline lung function. He had a surveillance bronchoscopy, and the biopsies showed no signs of acute cellular rejection, A0, B0. The BAL was positive for Pseudomonas aeruginosa, and this was a multi-drug resistant organism, which the patient had predating his transplant. About 7 weeks later, in late October of 2025, this is now approximately 8 months after his lung transplant, the patient presented to the emergency department with acute hypoxemic respiratory failure. He'd had symptoms for approximately a week with some cough, some dyspnea, and some hypoxemia that he noted. Those symptoms were progressively worse and led him to come to the emergency department. On presentation, he was afebrile, but he was tachypnic and tachycardic. He required high flow oxygen because of hypoxemia. His chest x-ray on presentation is shown on the right of the slide, and what's notable is bilateral patchy interstitial opacities fairly diffusely throughout both lung fields, and small bilateral pleural effusions. He was admitted to the intensive care unit because of the severity of hypoxemia and started on empiric antibiotics. And so the first point to make is, should he have any additional testing? Are we comfortable that this is pneumonia from Pseudomonas, which was the admitting diagnosis given the past history of Pseudomonas cultures from his bronchoscopy testing? We were suspicious that this was not an infectious process and checked a DSA test. The patient had never had DSA prior to this presentation, and we'll go through the details, but he had de novo DSA detected. Now, what additional testing should the patient have? He had a CT scan, which shows similar findings to the chest X-ray with ground glass opacities throughout both lung fields and some consolidative opacities in the lower lobes. The patient went on to have transbronchial lung biopsies and a bronchoscopy and BAL, and blood in Streck tubes for cell-free DNA, and we'll go through those details. I'm going to hand it to Michelle for the DSA.
Thank you very much, Ramsey. Good afternoon or good morning, everybody. So nice to be here and present this multidisciplinary case. So I am Associate Director of the laboratory at UCLA, and I am going to present the results of testing that would have been resulted for this patient from the immunogenetics and histocompatibility lab. We're going to review the HLA typing of the patient and donor, the virtual and allo crossmatch, and the pre- and post-transplant donor-specific antibody profiles. Next slide, please. Thank you. So for this patient, he was listed for transplant in July of 2024 and transplanted in February of 2025. The donor was an 11 out of 12 mismatch, and the typing for the patient and the donor are shown below. The patient was non-sensitized prior to transplant with a CPRA of 0%, and his virtual crossmatch was negative for current or historic donor-specific antibodies. And in correlation to that, the T and B cell cyto and flow allo crossmatches were also negative. Next slide. So the patient had no donor-specific antibodies pre-transplant, as shown in the longitudinal line graph here. He was transplanted in February of 25, and went on for quite a while with no donor-specific antibodies, and then encountered these bouts of Pseudomonas, and then beginning in September of 25, had his first occurrence of donor-specific antibodies to DQ2, shown in green, and DR17, shown in yellow. These donor-specific antibodies were first weak and became stronger, and ultimately the patient had a biopsy, which we will discuss. But before we do that, next slide, please, I wanted to discuss a little bit in detail about the Luminex-based single antigen bead test. This is the most sensitive and specific test that we have in the laboratory for identifying donor-specific antibodies. It's Luminex based, and so each bead is coated with one single antigen. Each of these beads is also charged with a certain amount of dye. And when we mix the patient's serum with the bead will, the antibody in the patient's serum will bind to the bead and then be detected by a secondary detection reagent in Luminex. The raw data looks like what you see there on the right. Each bar is the reactivity of an antibody to one single bead, and some in this case are very strong and others are weak and others are negative. Next slide. But there are some caveats to the single antigen bead test that we are well aware of. So as shown in panel B, if the antibody in the serum is in excess, then it can be difficult to really understand the strength of the antibody because so much antibody is binding to the bead, all of the antibody can't bind because of that excess, and the results will exceed the dynamic range of the test. The dynamic range is noted there. It's around 1,000 to 12,000 roughly MFI, and above 12,000 to say 15,000, you can't tell if an antibody is strong or really, really strong, for example. Another caveat of the test is inhibition. So there can actually be inhibitory factors in the serum, such as complement, which can prevent the secondary detection reagent from binding to the HLA IgG. And when this occurs, we see a abnormally or unexpectedly low result, which is actually also inaccurate. I have examples of this in the next slide. Thank you. So here are some examples of some single antigen bead data. I have antibodies that have been identified in undiluted and diluted serum, antibodies to A1, A3, A23, and A24. In undiluted serum, antibodies to A23 and 24 are strong, around 10 to 12,000. And when we dilute the serum, we find that those antibodies are still very strong. And these are examples of saturation. While for antibodies to A1 and A3, in undiluted serum, we have a strength between, for one of them, 1,100, for the other 5,000. But when we dilute the serum, the strength increases fairly significantly into the 15,000 range. And this is an example of the kind of data you will find when there are inhibitory factors in the serum. And this is why dilution of the serum in the single antigen bead test can be very effective at help us understanding the true strength of antibodies and donor-specific antibodies. Next slide, please. Thank you. So when we look here at the patient's longitudinal data, the strength of the donor-specific antibodies to DR17 shown in yellow and DQ2, this is an undiluted serum. We find that the antibodies came up around September 15th. They became stronger and then stronger and stronger. But when we dilute the serum at each time point, in the next slide, thank you. What we found is that both of the antibodies actually dilute down to almost negative on 10-1 with dilution. But by 10-9, the antibody to DQ2 has continued to grow in strength, while the antibody to DR17 still dilutes down to a more to a value which is in range, in the dynamic range of the test. And so we can infer from this data that the DQ2 antibody is much stronger than the donor-specific antibody to DR17, at least as far as shown here, October 9th and then November 1st. Thank you, and now I'll pass it over to my colleague, Dr. Calabrese, to review the biopsy results.
Thanks, Michelle. Good morning, or good afternoon, or good evening, everybody attending the webinar. I would like to briefly thank all the ISHLT organizers and above all, both moderators, Adriana and Ramsey, for their excellent coordination. So the case we are discussing today, as previously anticipated, is not an exceptional or rare case, but rather a real-life case. And we selected it because it clearly illustrates how several specialists work together, each contributing their own tools and expertise to refine and improve the diagnostic algorithm of this very challenging diagnosis. And in this setting, how does the pathologist work? Next, please. Next slide, please. Thank you. Back to our patient. The patient underwent bronchoscopy at time of respiratory dysfunction, and the bronchoscopy provided a very good number and adequate sample, 7 pieces, 2 out of them containing small and large airways. The high magnification of one of the samples showed a huge macrophagic alveolitis. And this is an expected finding based on the GGO diffuse ground glass opacity detected on CT scan. Interestingly, the iron staining often performed along other spatial stain for collagen deposition or microorganism detection marked most of macrophages, as you see in blue. We usually call it hemosiderin-laden macrophagic alveolitis, and this usually suggests us a previous bleeding or basal damage. Next slide, please. Next. So focusing on another fragment, we detected an inflammation of alveolar septa, revealing at, next please, at high magnification, next please, a a neutrophilic margination with back-to-back neutrophils and a few apoptotic bodies. Next, please. And the high magnification of another sample, the sample less affected by crash artifact, revealed a septal edema and the capillary dilatation. Usually, capillary walls, capillary lumen are not so clearly seen in normal alveolar wall, as you can appreciate in this image on the left of the slide. Next, please. So we detected in our case widening of alveolar septa that now is recognized as an alert sign of MR. Pathologists take into consideration, or should take into consideration, the plausible mechanisms underlying septal widening is related to several factors, but surely one of the most important is related to endothelial changes. Endothelial changes, well studied at electron microscopy. Next slide. This was a study published 5 years ago. The authors analyzed several cases of MR, and the authors report several endothelial changes characterized by endothelial swelling, endothelial vacuolization, endothelial blebs, and basal membrane reduplication. Next, please. So septal widening is one of suggestive lesions, along other more frequent lesions, nicely arranged in this image panel of the 2018 Banff report. And this include endothelitis, different degree of capillary inflammation from mild neutrophilic margination, as we detected also in one of the fragments of our case, to the most severe form, neutrophilic capillaritis with blood extravasation and the severe parenchymal injury, named diffuse alveolar damage, organized pneumonia, and AFOP, acute fibrinous organized pneumonia, characterized by the presence of fibrin, intraalveolar fibrin and minimal inflammation in the alveolar septa. But these signs are not specific of MR. Next, please. Indeed, this lesion can be, for example, detected in several other injuries, for example, in different forms of infection. But pathologists are well aware that in non-oncological setting, highly specific histological lesions do not exist. So, and in this setting, how does the pathologist usually work? While the collection of clinical data are essential, even more important is the integration of ancillary tools. Next, please. Back to our case, all spatial stains for microorganism detection were carried out in either in transbronchial biopsy or bronchial alveolar lavage. Bronchial alveolar lavage represented the most important source for microorganism detection, and all were negative along traditional microbiological investigation, thus excluding at that time an active infection. And what about tissue AMR surrogates? One of the most known tissue AMR surrogates is the evaluation of fraction complex C4D. And the C4D immunostaining was performed in our sample and was negative, with positive background staining on elastic fibers that represent the internal positive control. But this is not surprising, since this marker is well-known low sensitivity, especially in lung MR. Next, please. Next. And what about another tissue AMR surrogate that is increasingly used in several pathology labs, phospho-S6 ribosomal protein? This is a phosphorylated protein of the mTOR pathway that has been demonstrated overexpressed in AMR of several solid organ transplants, cardiac AMR, kidney AMR, and also lung. So the immunostaining was carried out also in our case, but the immunostaining was not so supportive. We detected only mild, moderate staining of macrophages. Next, please. Phosphorylated S6 ribosomal protein has been demonstrated to have a higher sensitivity than C4D. And it is also demonstrated positive in either complement-dependent or complement-independent AMR. But however, its specificity is high only when we detected the immunostaining in different cell phenotypes, macrophages, epithelium, and above all, endothelial cells. Next, please. I'm showing you now what we consider strongly immunostaining of this marker. We usually call it black sample. Why black sample? Because we detected immunostaining in different cell phenotypes, macrophages, epithelium, and above all, endothelial cells. This, the biopsy comes from a patient who developed 1 year after transplantation, graft dysfunction, and a weak de novo DSA. And interestingly, at histology, we detected a complex immunological disorders, acute cellular rejection A2, and plus suggestive signs of MR. And interestingly, in this case, we detected both tissue AMR surrogate positive, C4D and phospho-S6 ribosomal protein. Next, please. So in conclusion, in our case, none of the tissue AMR surrogate supported the AMR diagnosis. But currently, are there any additional marker that we can add in the diagnostic algorithm? For that, I'll hand over to Sean to introduce and discuss this other important tool. Please, Sean, the floor is yours.
Okay. Now, thank you very much, and really special thanks to ISHLT, to Adriana, and to Ramsey for organizing this. It's amazing that I just finished fellowship in 2015. At that time, we were debating whether there is an AMR construct in lung transplantation. It's amazing that we can have a seminar. It really speaks to our community how much we can come together, identify problems, strive to try to fix them. I cannot be more proud to belong here. So thank you for setting up this stage, ISHLT, for all of us to thrive, blossom, but more importantly, bring new constructs that can help our patients. Cell-free DNA. These are really wonderful stores of information on pathobiology. I'll start here and then I'll come back to our case in hand and how it applies. This is very abundant molecule that is present in plasma and is secreted from all kinds of sources, whether it's the nuclear from the host or the recipient cell-free DNA that I have here as nuclear, or the donor, or from microbial cell-free DNA. Next, please. So there are several sources of that. I will really focus initially on the donor cell-free DNA. As you know, the lung transplant construct, like other allotransplant construct, gives you a mixture of two genomes. There's a genome from the donor, which we'll call donor cell-free DNA, and a genome from the recipient. And so if you take plasma then from that patient, it's extremely important to process that plasma very quickly or collect it in specialized tubes to avoid contamination of the cell-free DNA from cellular DNA. But if you get clean, good quality plasma, therefore, in that plasma, represented here in red, would be cell-free DNA from the host or the recipient versus cell-free DNA from the donor or donor cell-free DNA. And you can use whatever method you want, digital droplet PCR sequencing, to quantitate the percent of donor-derived cell-free DNA as a fraction of rejection. Next, please. Another next. Excellent. So I want to emphasize that the test that is commercially available, that's available clinically, really now, a lot of it really just gives us this fraction. This is a prototype patient, and the goal of this is to show the reproducibility of the test, independent of the methods being used. It's very reproducible. This is in the y-axis is your fraction of cell-free DNA, and on your x-axis is time. This is a heart transplant patient from Stanford, and in blue is this replicate samples measured in Steve Quick's lab at Stanford, and in red is replicate samples measured in my lab at the NIH. They really just superimpose on one another. It's a very replicable test. Next, please. Back to our patient in hand. And I overlay the cell-free DNA here in red. Again, this is percent cell-free DNA, and the axis is on the right-hand side. As you could see in this patient, they were transplanted, they got a Pseudomonas infection, they had a small rise in their cell-free DNA. I suspect that Pseudomonas infection was treated. Again, cell-free DNA is here in red. It comes down, and as the patient develops DSA, you have that patient show a rise in their cell-free DNA until ultimately they develop AMR. I would like to emphasize two core principles here. The first is that with this Pseudomonas infection, as we see infection that is true infection, you can have a rise in cell-free DNA as well, just as in rejection. The second is that at the time of AMR diagnosis, your cell-free DNA levels are high. But more importantly, preceding that diagnosis of AMR, you have a rise in cell-free DNA preceding that diagnosis of AMR. And it wasn't just in this case that we saw. Next, please. If this is a cohort of lung transplant patient in which time 0 is the time that we make that clinical diagnosis of AMR. As you can see there, your percent donor-derived cell-free DNA is high, and it's high 2 to 4 months before that diagnosis is made. Indeed, 75% of patients with antibody-mediated rejection will show this. This is some work that was done by Moon from the Graft Consortium. We've shown this in lung transplant, and we've shown this next place. Next again. And similar pattern in heart transplant as well. A rise in cell-free DNA preceding that diagnosis of antibody-mediated rejection. Next, please. I want to come back to cell-free DNA because the nuances in cell-free DNA, some work I'd consider really seminal work that was published out from St. Joe's there, which showed cell-free DNA measured as percent and did not show the kind of performance that we showed in graft. I would like for us to focus our attention to this formula. This is the test that is reported here. As you see, it's reported as a percent of donor divided by donor plus recipient, and it makes two assumptions. The first assumption is that you're measuring donor. The second, next please, is that the recipient or the host cell-free DNA is low and constant. Doesn't change. If we know anything about transplant, you know that sometimes that is not the case. Next, please. This is work that was led by Multi-Disciplinary and Abate from the Graft Consortium that just measured recipient cell-free DNA in the host over time in about over 200 transplant patients. You will note the following. The median of the population is shown there in the blue line. Next, please. If you look at healthy patients, their cell-free DNA is about where the red line is. Two observations. Men, lung transplant patients have really high cell-free DNA levels. Second, the recipient or the host cell-free DNA is not only high, but is hypervariable between patients and hypervariable over time. So if you come back to that equation, next please. Will your percent cell-free DNA represented as percent, while it shows really good performance in a population-based study, if you look at an individual patient, will it always stand that case? This is another patient from the Graft Consortium that developed AMR. In red is the percent cell-free DNA. If we follow that red, you could see that the patient's cell-free DNA was generally low. Look at the right axis, a little less than 0.5%. As the patient gets AMR, the level actually decreases. This is a patient that showed high recipient cell-free DNA, 69,000 copies. That's very high at that time of AMR. If you look at the, go back, please, if you stay here, please. If you look at the absolute copies of cell-free DNA, which is in blue, you will see that the absolute copies of cell-free DNA, which is in copies per ml of plasma, show the expected rise in cell-free DNA. So if you see your patients, there's a high clinical suspicion and your percent cell-free DNA is low, it's not all is lost. Or it's not that the percent cell-free DNA may be, for these specific patients, your recipient cell-free DNA would be low. This is not to say, I'll emphasize this, and this is my last point, and I'll pass it back to Ramsey. This is not to say absolute copies of cell-free DNA is better than percent. No. There should be dedicated studies to emphasize this point. Again, I'm emphasizing here that we're looking at individual cases, and you can use different variables of cell-free DNA to further understand what is going on. Cell-free DNA being represented here as a reliable marker of allograft injury. I'll stop here and I'll pass it back. Next, please.
Thank you, Sean, for that nuanced explanation of cell-free DNA and accounting for the recipient's cell-free DNA. So coming back to our case presentation, this is the upcoming ISHLT definition for AMR that uses what we call the GAP definition, or GAP. And here, G stands for graft dysfunction, A for antibodies, P pathology, and complement activation, or C, is considered a non-core component of the definition. So for our case, there was evidence of graft dysfunction with hypoxemic respiratory failure. So for the G component, the patient would get a score of 1, and that's shown in the red box. For antibodies, the patient has strong HLA-DSA with an MFI greater than 8,000 that are present. And so the antibody score would be A4. And then for pathology, the biopsies showed histologic findings that are frequently detected in AMR, as Fiorello went through: diffuse alveolar damage, organizing pneumonia, acute fibrinous and organizing pneumonia, capillary inflammation, septal widening, endothelialitis, and microthrombi. So those were present, and that's a P1 score. So the GAP definition would be G1, A4, P1, illustrating the findings that are seen in this specific case. So in terms of treatment, when a diagnosis was made and the subsequent outcome, the patient was treated with a combination of therapies, as is often done at most centers. The patient was treated with a course of antithymocyte globulin, as well as plasma exchange. He received carfilzomib, but only tolerated 2 doses because of acute kidney injury, and was given IVIG. He had improvement in his oxygenation and actually did not require supplemental oxygen at the time of discharge from the hospital. Unfortunately, with follow-up, he's developed CLAD, and his course has been progressive. Recent clinic visit with pulmonary function tests show an FEV1 of 1.27 liters, which is 39% predicted. Remember, his baseline lung function before this episode of AMR had an FEV1 that was approximately 83% predicted. Unfortunately, this is a common clinical course where there's what appears to be an initial improvement. The patient no longer requires oxygen and can go home from the hospital, but there's progressive CLAD. So Michelle, I'll ask you to comment on these DSA data here.
Sure, no problem. Thank you. So extending the longitudinal data to the right and adding more dates The patient was treated beginning around the beginning of November of 25, but his donor-specific antibodies to DQ2 and DR17 remain strong in the undiluted serum. The cfDNA did increase and had a peak, and then over time decreased somewhat, but never went back down to baseline levels. Next slide, please. Looking in the comparing undiluted serum to the results of serum that is diluted, what we found is that the donor-specific antibody to DR17 continued to increase in strength. This is shown in the results of the diluted serum. We see that over time, the strength of DR17 almost is identical to the strength of the DQ2 by January 12th of 26. And I just want to thank everybody for your time and attention and pass it back to Ramsey for our key takeaways.
Thank you, Michelle. These are our takeaway points from this case that we'd like to emphasize. There are several risk factors that may be considered for the development of AMR after lung transplantation, and infections in particular with Pseudomonas have been associated with the subsequent development of AMR. AMR frequently results in progressive CLAD in spite of initial clinical response to treatment. And the integration of several investigations, including histology, immunohistochemistry for AMR surrogates, donor-derived cell-free DNA, and hopefully upcoming new biomarkers reinforce the AMR diagnosis. The persistence of strong DSA and high donor-derived cell-free DNA can predict the clinical outcome. And obviously, in light of the poor outcome for many of our patients with AMR, this illustrates that there's a critical unmet need to identify better treatments for AMR. So thank you all, and we have time for a discussion. I'm going to take the slides off.
Thank you, everybody, for attending, and I am so thankful for this excellent presentation. I think we all learned a lot, and there's plenty of time for some discussion. I think we have an excellent team here of clinicians and histocompatibility pathology that can further our discussion in terms of what could we do better. I'm looking to some of the questions, and one of them is to Dr. Ramsey, asking why you choose carfilzomib versus rituximab. What prompted the choice? As we spoke earlier, treatment is quite a mixed bag for different patients. So, Ramsey.
Yeah, no, that's a terrific question, and the short answer is, unfortunately, we don't have a good evidence base to guide our management. We've used evidence from other organ transplants, although I don't know that that's necessarily the best approach to guide our management. And so what you see across centers across the world is different centers have different protocols. We've adopted the protocol that includes carfilzomib, and the initial study that was done in lung was at the University of Pittsburgh. And we've adopted that regimen in the place of rituximab, mainly because of how quickly it acts as opposed to rituximab, which would have a delayed onset of action on B cells and limited effect on plasma cells. Whereas with carfilzomib, I think you can expect to see an earlier response. Having said that, I will admit that this is all theoretical. It's not as though we have a clinical trial that shows that carfilzomib is somehow superior to rituximab. Now, we need to do these clinical trials, and that was my last point, that there's a unmet need for good data to guide our management.
Thank you, Dr. Ramsey. I think the next questions are very pointed to the ability perhaps to identify earlier an event, a clinical event, and can we use the different testing? For Michelle, did you consider longitudinally assessing the complement binding capacity of before that? Can you comment on your DSA and cell-free DNA surveillance approach? I think Michelle will be the first, Sin second, and then Dr. Calabrese Fiorella has a slide that can show how they integrated in their institution using those two tests. Michelle.
Thank you so much to everyone in the chat who has added these important questions. As Ramsey pointed out with respect to treatment, that there is no one accepted method of treatment. Similarly, there is not one accepted method for timing of testing across all centers. And so with this case, what we tried to show was that with the rising cfDNA, trying to understand at that time, was it infection? Is it an alloimmune response? It made sense to also show that we would test for donor-specific antibodies and find at that time new weak donor-specific antibodies indicating the rise of an alloimmune response. With respect to checking for complement binding, we didn't present that in this in this webinar for one reason. Complement binding has been moved to a non-core element of the gap diagnosis for antibody-mediated rejection. In my laboratory, we are using a lot of serum dilution and rerunning of single antigen to identify strong antibodies. These are usually also antibodies that would bind complement in the C1q assay, but we have experienced some trouble with QCing the C1q assay in the past couple of years since the pandemic affected supply chain. So we are at this time primarily using serum dilution. Adriana, shall I continue? I'm not sure what the next question was.
No, I think I would like to continue on the integration of cell-free DNA.
Thank you.
Together with the injury and the specificity of the antibody. I think this is a very important concept.
Thank you.
Dr. Akbar.
Yes, thank you for that question. And truly, I see the questions. Please keep bringing them, you guys. Wonderful audience participation. So you ask a very good question. And I think it hits on the fundamental definition of antibody-mediated rejection, which is some version of rejection, which is triggered by antibodies. Therefore, if you define rejection as the presence of antibodies plus the association of those antibodies with a measurement of allograft injury, then could there be a construct which, allow me to call it molecular AMR, it's a term we coined in the graft consortium. Could there be a construct where the presence of DSA plus elevated cell-free DNA, which measures allograft injury, could be predictive or indicative of antibody-mediated rejection? Michael Keller from the Graft Consortium led a study that was published in ISHLT. In that construct, we ask a simple question. If you have cell-free DNA that is positive, greater than 1%, plus the presence of DSA, how likely are you to have AMR constructed by these ISHLT criteria? Not only was that approach sensitive, but it detected other instances which did not meet this criteria, and those instances that did not meet the ISHLT criteria also similarly increase the patient's risk of CLAD. So the construct, that's just a small observational study. There's much more larger studies within the Graft Consortium and others that is asking just that question. If you combine DSA and cell-free DNA, could you diagnose AMR, and could you do that earlier with greater specificity? So we have advocated measuring DSA and cell-free DNA within the graft consortium. But the frequency in which you do this really needs to be a risk-benefit ratio, right? Because these tests none of them is cheap, right? So I think each center, while we're waiting for clinical trials, each center needs to somehow figure this out, depending on these factors, the risk of their patients, and also how much this is costing to run these assays. We did one study during the COVID-19 pandemic, and at the time we had no choice, right? So I want to make sure I specify that. At the time we had no choice because bronchoscopies were not done. In that study, we measured DSA and cell-free DNA monthly in our patients. And that monthly, then we're able to reliably monitor for AMR easily. But that was within the pandemic. A lot of things were closed. And so that was that specific structure. So I'll stop here and pass it back to Adriana to see, to get further comments.
Yeah, well, thank you very much. I think we have a very nice summary slide from Dr. Calabrese that she was so kind to share what they do in their institution in terms of integrating the cell-free DNA.
Ramsey, do you want to share?
This is the slide after.
Yes, this is a pathology diagnostic algorithm that we are using in our center. This is just drawing on oncological experience with liquid biopsy. In other words, let's start. If, for example, we have a case with high suspicions of a clinical AMR, as our case, and we perform the biopsy, first of all, we ask if the biopsy is adequate. If the biopsy is adequate, if we detect suggestive signs of AMR, and we soon proceed with AMR surrogates. If the AMR surrogates are positive, this is a likely AMR, or this could be AMR, definite AMR, especially if donor-derived cell-free DNA is higher than 1%. If the biopsy we don't see any signs of AMR suggestive injury, and all the AMR surrogates are negative, this is unlikely an AMR, especially if donor-derived cell-free DNA is low. But if I don't see AMR suggestive lesions, and I have a donor-derived cell-free DNA higher than 1%, this could be still unlikely AMR. Why? Because in the biopsy, we know we could have a sampling error. And in this case, again, donor-derived cell-free DNA can help significantly in the diagnostic algorithm. If the biopsy is inadequate, obviously we strongly suggest to repeat the biopsy if patient condition permits, but this is again the voice of pathologists, but also by our clinicians that strongly believe in the value of biopsy. But if the patient has a poor condition, this is also what we draw on from the liquid biopsy in oncological field. Again, donor-derived cell-free DNA is one of the most important tools that can help us in the diagnostic algorithm.
Thank you very much. I think this was a very informative addition to our discussion. I would like to take the prerogative of moderator just to mention one big change from previous to definition to today was the fact that we just look to the DSA, yes, no. And I think that is a very important concept that has to be kind of understood and introduced, because combining with cell-free DNA, we can again see how an increasing in level, titer, or complement binding, depending on what the laboratory can do, will show a much better correlation with the injury. And previously, we just said yes, no, and that is not enough today to really evaluate the importance of antibody presence. And if there is no HLA antibody and we see cell-free DNA increasing, it's very important indeed to look for outside of the donor-specific HLA antibody. We have published and others, there's still a lot of room to improve because we don't have the best reagents, but there is indication. The non-HLA antibodies, Dr. Hashem had done a lot of work previously. There is a lot of work published that there is room to improve our ability to test and incorporate that. In the diagnosis, this is not a core question, but in fact, we have that question. Is there testing for non-HLA? Is that presence or not? So I think that's the future that has to be added. Now, there is another question here, more towards the treatment. And again, can you use both rituximab and proteasome inhibition when it's needed?
Yeah, that's a good question, and my answer to that is there's no reason that one could not do that, and we have done that in some cases. Again, I'm a little hesitant to make any treatment recommendations because our treatments have not been effective or successful, and we really don't know if the combination of rituximab and carfilzomib is superior to either alone or in combination with other drugs. Note that we included ATG, antithymocyte globulin, in the treatment, and I think there's often mixed rejection where there's cellular rejection as well as antibody-mediated rejection. And ATG does have an important role not only in treating cellular rejection, but also in antibody-mediated rejection. But what combination should we use and what's the best combination? I really can't say what the best combination is.
Adriana, could I add on
Sure.
to?
Please go ahead.
Yeah, so allow me to bring on another aspect of cell-free DNA to tie it to what Ramsey just said. I guess the question on the line that I wonder whether that question on the line that is, could we then have some markers that we could track very early on to know whether that patient is responding favorably to treatment? Again, there's a paper that Mike Keller from my research group published last year. We ask a simple question. If I look at the cell-free DNA 2-4 weeks or so after the treatment of rejection, could I estimate treatment response? And that being, would that patient show an increased risk of developing clot or dying? And if you look at that cell-free DNA after treatment, what you will notice is that the patients who show a low risk of developing clot, their cell-free DNA decreases and come back towards the baseline before that episode of AMR. If that cell-free DNA, even if it decreases, but remain above that baseline, the patient shows a significantly increased risk of clot. Again, we need studies to see what the clinical relevance is. But could this cell-free DNA after treatment be indicative of treatment, treatment response? And could those patients who do not show a decline in their cell-free DNA back to baseline, would they benefit from these additional therapies that you're proposing? Maybe bring on another agent, maybe bring on additional things. As Ramsey said, it's very hesitant to make treatment recommendations now, even without some guidelines or some studies to guide us to do that. And I'll stop here, Adriana.
Thank you very much. And I think for the few more minutes that we have, there is a growing question there in the chat. Number one is the role of the complement binding testing in the AMR diagnosis. I think we are looking either the antibody or in the tissue, but I want to remind everybody that graft damage can occur in the presence or in the absence of complement binding. So we have to think about that there is multiple mechanisms. And so that's number one. And then the other question, and I ask the panel to respond, how you would manage and prioritize the growing amount of histological, immunohistochemical, molecular, and the clinical data meaningfully to interpret. And that's why the title is Multi-Disciplinary.
Disciplinary, yes.
Correct? So, Fiorella, if you like to start, and then we go around the group.
I think as in the oncological field, we needed to improve the MDT rules. In other words, in non-transplant, but in general, in transplantation, we do not, for example, precise which are the main actors of the MDT. How can we report our MDT diagnosis? This is a part already done in oncological field. I think this is extremely important that we can do the same. In other words, we could produce, as in oncological field, a combined report that integrates all available information from histology, available information from immunological setting, and overall from DSA, just to have a final diagnostic report. This is what we are doing, for example, in lung cancer. In lung cancer, we usually integrate also the information of liquid biopsy. Okay, we routinely do this.
Could I add there, Adriana?
Yes.
Oh, sorry, Michelle, please go ahead.
Oh, thank you. I would love to also respond to the insightful question about how to integrate all of our data in the EMR. This is something that I work on quite a bit at UCLA with respect to our orders and reports interface to the various hospitals that we interface with, transplant programs. And I just wanted to say that this is a dream of mine, to be able to integrate all of our data in a meaningful way that will help in clinical decision making and patient safety. And it isn't possible without collaborative quality improvement, and also without the support of hospital and transplant administration, because it takes a lot of effort, a lot of validation, a lot of IT resources. And so I've been working on this for quite a while, and even with my efforts, I have yet to get this off the ground where I really, really want to. So I think that the more that we start asking this question in our transplant programs and in our centers, the closer we will come to having this.
Thank you, Michelle. Sim.
Okay. Yeah, if I may, I wonder what I can turn in back to us. Because Ramsey, let me see if I could bring this up here. It makes a difference when, as a society, we make recommendations and people can hold this up and go to the hospital administration and this. Currently, to make the diagnosis of AMR, even when you have data, it's very challenging. The patient get a PFT, they wait 3-4 days, we see a DSA, maybe we've forgotten about that PFT, I hope we don't. And then the histopathology shows up about a week later, maybe there's cell-free DNA the week after that, and we are running around seeing different patients. What if ISHLT came up as part of our recommendations? We say, center should establish a report, an AMR report, period. In that AMR report, it should pull data number 1, 2, 3, 4 in the same sheet. Would that help a doctor make that diagnosis even easier? I will stop here.
Ramsey.
Yeah, I think that would be a terrific idea to do that. The only hesitation that I have is if we were to recommend that across the board, there might be pushback by someone saying, well, show me the evidence that improves outcomes, or that improves the diagnosis or facilitates the diagnosis. And I think it would improve the diagnosis and facilitate the diagnosis and hopefully would improve outcomes, but we don't have those data to say, based on these data, we recommend the following. Now, having said that, there isn't anything to prevent a program from developing that kind of report and say, okay, we're going to have an AMR report just like we follow PFTs to make the diagnosis of CLAD, and many centers have integrated their pulmonary function lab results into their notes so that when you see a patient, you get all of the previous pulmonary function results and what percent of post-transplant baseline a patient is at during that visit. You could develop your own homegrown report that integrates DSA results, clinical graft function, histology, and put it together. So yeah, that would be my my response.
I would like to add to that, just a second, Fiorella. The only thing I would like to add to that at this point, it's communication between like the laboratory to the clinician, which in our institution happens immediately. There is a requirement for the DSA the same day. If there is a clinical indication, the same day is done, and we pick up the phone or email or do that directly. So I think communication is absolutely necessary, not a week after, 24 hours. And that's what it will help. I think the same thing is done in the various institutions where really the need of the information to channel to the clinicians to help. If I need to do a dilution, if I need to do something, it will be maybe one day delayed, but we explain why. So I think right now is education, communication are very important to move the needle.
I absolutely agree with that. And Sean, thank you for that question. I wanted to say that for kidney transplant, Dr. Sheenstock and colleagues wrote like a BAMF report analyzing data from nephrologists and surgeons, which one of their calls to action was a more integrated report and improvement in access to data for patient care. So other societies have done this, and I think that it's doable anywhere. And it only helps us to then gain resources for these kind of things. And with respect to communication of results, I absolutely agree with you, Adriana. And my vision for this is that based on critical alert values, there would be a form of like multidisciplinary daily even rounds for patients who need to have like critical decisions made based on their new data.
Fiorella.
Yes, I fully agree that communication is absolutely mandatory. But establish, for example, a weekly meeting, MDT, in which all the specialists discuss together the results. I think this is an important goal that we have to reach, as we are doing for interstitial lung disease or in oncological field.
Well, thank you very much. If anybody wants to add anything, we are exactly at around the hour. I could not ask a better team. I call them the dream team, and they were. Thank you so much for the hard work to put together. Thank you for your time, and I hope that the participants had the opportunity to see in real life and learn how this integration can happen in any institution. Thank you all. Thank you, the participants. And I think with that, we are concluding this webinar. And if there is a need, could be a continuum discussion on ISHLT Connect, the page of the immunology, research in immunology. Thank you very much.